Thank you very much. I hope you can hear me back there. This is a very difficult time to give a lecture because everybody's kind of half asleep and it's late in the afternoon. I hope you're not tired. But I decided when I was asked to give a presentation on chronic diarrhea to have an interactive presentation and try to share with you some concepts and some real cases to engage you in a discussion. So let's try to do this. This is a format that we like at Stanford. It has to do with a case presentation and allows us to expand on certain themes. So the first thing is to discuss diarrhea is what kinds of diarrheas do we have? There are 4 different types, and if you can actually distinguish practically as you take the history of what you're dealing with, you can actually have most of the answers right there. The first element is the so-called osmotic diarrhea, which means that if you fast the patient stops eating, the diarrhea resolves or gets better significantly. So a very easy test is you say to the patient, stop eating, and find out what happens a few hours later. Then if the diarrhea is osmotic, the diarrhea will stop. A second element is, a second type of diarrhea is a secretory diarrhea, which persists despite fasting. So if the patient fasts for, let's say, 12 hours or 24 hours, and the diarrhea persists, then you have some kind of a secretagogue that produces that diarrhea. So that's a very important next question that you have to address. The third type is exudative, which means that there is some degree of mucosal damage in the tissue of the bowel, be it the colon most commonly or the small bowel, that creates this diarrheal activity. And this is some kind of an inflammatory process. It could be an infection or it could be an idiopathic inflammatory bowel disease. And finally, and probably the most common form of chronic diarrhea in particular, is what we call the motor diarrhea, which reflects abnormal motility of the gut muscle. And the patient, typically a patient with irritable bowel syndrome, presents with episodes of diarrhea that come and go, come and go, come and go, a reflective overactivity of the muscle. So this basic categorization of diarrhea is a very practical one at the primary care level and will help you a lot in distinguishing what you're dealing with. There are several questions that you would always have to ask. First, is there a bloody stool, which means that there's some kind of a damage? Second, is there any fever, dehydration, or collapse of the blood pressure, for example, with tachycardia, hypotension? That means that you may have to consider hospitalization. Is this a high-volume diarrhea versus a low-volume diarrhea? High volume means that the patient has a lot of bowel activity, a lot of fluid, almost like cholera, for example, typically the case with cholera or dysentery, versus a low-volume diarrhea, which the patient has frequent bowel movements, but a very low volume, which is less likely to dehydrate the patient. And again, high volume usually implies a small bowel process that releases a lot of fluid. Low volume means that there is possibly even a limited distal rectal inflammation that causes the activity or the frequency of the evacuation, but usually not in very significant volumes. Is there any tenesmus, which is obviously a Greek word, you understand it better than my American colleagues, which means the tendency to have to go to the bathroom after you just finished going to the bathroom. This urgency to repeat and repeat and repeat, that usually denotes some problem at the level of the rectum or the distal colon. Another important question is recent travel, travel to some kind of an exotic destination that you brought back some infection, either bacterial or parasitic. A very important question is about the prior or concomitant use of antibiotics, because antibiotic-associated diarrhea, specifically Clostridium difficile infection, is very common, particularly in individuals who have spent some time either in a chronic care facility or in a hospital. And finally, the level of immune competence of the particular patient, to what degree that person is going to be able to sustain the burden of the diarrhea or not, and to what degree you have to consider other elements. Is this patient, for example, predisposed to develop this diarrhea or some kind of an unusual form of infection because they are immunocompromised. They have, for example, HIV infection or other serious immunocompromising states. So these are all key questions that if we ask all the time and we do this as a habit, then we will pick up a lot of important clues from the patient that will help us in our diagnosis and management. A few more key points. Acute diarrhea means that it's less than 2 weeks in duration. If it's more than 4 weeks in duration, we call it chronic. If we have a patient presenting with oily residue in the stool, we should consider that on top of the diarrhea, we're dealing with a malabsorptive process, typically of fat. A response to an empiric course of antibiotics is often the best test for a situation called small bowel overgrowth syndrome, which is very common in the population. The diarrhea associated with pancreatic insufficiency responds to pancreatic enzymes, and this is a significant possibility in people with chronic diarrhea. And finally, there is an entity called microscopic colitis, which is not something that we detect visually by endoscopic examination, but we need to take biopsies, and it's associated with watery diarrhea, and it's frequently seen in middle-aged or older individuals, particularly women. So these are important key elements in our thinking as we face with a particular patient with diarrhea. So let's go with some cases together, and we'll learn a few things along the way. This is a 26-year-old woman who is evaluated for a 3-year history of intermittent, crampy abdominal pain associated with diarrhea and bloating. She was previously diagnosed with irritable bowel syndrome, or IBS. She has no blood in the stool, no weight loss, no nocturnal activity of her bowels. She takes a levothyroxine for hypothyroidism, and she has a negative family history. Her vital signs are normal. Her body mass index is normal. Examination of the neck is normal. The abdomen is soft, non-tender to palpation, and has normal bowel sounds. The rectal examination is also normal. Which of the following is the most appropriate next step? First, to consider doing a colonoscopy. Second, to perform a hydrogen breath test, which is a test that detects small bowel bacterial contamination. Third, to use an antibiotic called rifaximin. And fourth, to use a test called serum tissue transglutaminase testing, which is a test for celiac disease or gluten-sensitive enteropathy. So as you keep thinking, I will give you the answer. And the answer is serum tissue glutaminase testing. And I would like to elaborate on this as an opportunity to discuss an important condition that can present in a subtle way, as you heard, and this is a condition called celiac disease. And this is a condition that should be diagnosed or should be thought of in the primary care setting. It's affecting 1% of the persons in the United States. The prevalence in patients with irritable bowel syndrome, like this particular case, is as high as 4%. And this testing is sensitive and specific and can be used for screening. It's a simple blood test that you can order in your office in your local lab. There is no role for colonoscopy in the patient with symptoms compatible with irritable bowel syndrome in the absence of alarm symptoms such as bleeding, weight loss, sudden change in bowel habits, family history of colorectal cancer, or onset at greater than 50 years of age. And rifaximin helps patients with symptoms of IBS, but the important point here was that you picked up at the primary care level a celiac disease case, which is a very important diagnosis and has significant implications. So a few words about the disease. It's an inflammatory condition of the small bowel. It's induced by gluten. It's a multisystemic disorder. It's common and may be diagnosed at any age. It's closely linked to specific HLA alleles, and it depends on the environmental factor of so-called gluten, and removal of the gluten from the diet is curative and helps this patient for life. An endoscopic appearance you see here, you have all kinds of characteristic things, but if you make the diagnosis by the blood test, you don't really need to do this necessarily. I'm just showing you some pretty images of what we do as gastroenterologists to define the disease further. Histology is characterized by atrophy of the villi of the small intestine and significant degree of inflammation at the level of the mucosa. There are several associated conditions that we need to be aware of, and you as primary care physicians, you need to consider. People who fail to thrive, people who have short stature, people who are first-degree relatives of patients with celiac disease, people who present with chronic tiredness and fatigue, people who have type 1 insulin-dependent diabetes. All of these people could be actually vulnerable to this condition of celiac sprue, and they should be considered for appropriate screening. There are other categories of patients, those who have a condition called dermatitis herpetiformis, reduced bone density. How many people do you see with osteopenia? You should consider that diagnosis because it leads to malabsorption of calcium and vitamin D. People who have ataxia or peripheral neuropathy, people who present with anemia for no clear reason, no bleeding, people who have iron, folic acid, or B12 deficiency, or even patients who have primary biliary cirrhosis or autoimmune hepatitis. All of these patients may have a higher probability of having gluten sensitivity and celiac sprue, and they should be considered and screened. So let's go to another case. This is a 51-year-old woman with a type 1 diabetes who is evaluated for a 5-year history of large volume, non-bloody diarrhea that occurs several times a day, waking her at night. She has significant bloating and gas, but no abdominal pain. The stool is not oily, and she has not lost any weight. The patient's diabetes is complicated by peripheral neuropathy and diabetic nephropathy, and she also has hypothyroidism. Her medications are insulin, levothyroxine, lisinopril, duloxetine, and pregabalin. Physical examination is normal. Her sugar is a little bit high. Her hemoglobin A1C is also high at 8.7, and she has a creatinine of 1.6. Her complete blood count, thyroid-stimulating hormone, and other routine laboratory values are normal. A tissue transglutaminase and anti-endomysial antibodies are negative. She has a breath test for bacterial overgrowth that is negative, and endoscopy and colonoscopy with random biopsies are normal. In addition to improve control of her diabetes, which of the following is the most appropriate next step in the management of this patient? Antibiotic therapy, diphenokylate with atropine, so-called Lomotil, gluten-free diet, or octreotide. These are 4 choices, and hopefully by now you have figured out the answer, and the answer is diphenokylate with atropine. So this is a dysmotility associated with diabetes, and this is a common scenario, and those of you who see diabetic patients will encounter it for sure sooner or later. It manifests with diarrhea that's typically painless, low volume, nocturnal, and generally quite incapacitating for the patient. You may have to correct fluid and electrolyte and nutritional deficiencies, and you have to be able to try to make the best effort to control the diabetes. The diphenokylate atropine therapy is the most appropriate therapy, but also you may have to use higher guns like a deodorized tincture of opium sometimes, which is obviously a very significant difference from diphenokylate with atropine. This particular patient had been screened for sprue, so that's not an issue. And octreotide may treat the diarrhea related to diabetic-associated autonomic dysmotility, but it could be complicated by recurrent episodes of hypoglycemia due to reduced secretion of counter-regulatory hormones, and that's why this was not a best choice for this particular patient. And if it's going to be a choice, it has to be very carefully monitored. And this is a slide that just reminds you that there is a connection between the autonomic neuropathy of diabetes and the enteric nervous system of the gut. And you will see a lot of patients complaining of all kinds of syndromes, of diarrhea, sometimes constipations, frequently fecal incontinence, a variety of manifestations of diabetes, including abdominal pain, by the way, that are all reflective of the autonomic neuropathy that takes place in diabetics, particularly those who have type 1 diabetes. The third case, a 68-year-old man with a history of alcoholism is evaluated for a 7-month history of diarrhea, during which he has noted an increased volume of stool. He has had intermittent abdominal pain, but not severe enough to prevent him from eating or drinking. He is not taking any medications. On physical examination, the abdomen is soft with mild periumbilical tenderness and no distension. Laboratory studies show a high AST of 155, a high ALT of 88, alkaline phosphatase normal at 96, bilirubin of 1.1, which is normal, amylase is 65 and lipase is 70, and there is fat in the stool. This is the abdominal CT scan of this patient, and I would like to point your attention to some white areas that I cannot point there, but in the middle of the area of the pancreas. So which of the following is the most appropriate management for this particular patient? Fiber, cholestyramine, loperamide, or pancreatic enzymes? And the answer is pancreatic enzymes. This was a case of calcifying chronic pancreatitis, and what you saw earlier on the scan was the white calcifications of the pancreatic parenchyma as well as the pancreatic ductal system. The patient also has concomitant alcoholic liver disease resulting from alcohol use, and the pancreatic enzymes will resolve the patient's diarrhea and can be used as a trial even at the primary care level without even involving a gastroenterologist. Fiber would bulk up the stool but will not address the malabsorption. Cholestyramine will bind bile salts, which is not the patient's primary problem, and loperamide will slow down the gut motility, but the patient will continue to have fat malabsorption and therefore will continue to have an element of diarrhea as well. And this is a study that looks at placebo versus pancreolipase, and you can appreciate here that you can improve the absorption of fat and therefore less fat in the gut, less diarrhea, and less malabsorption, with improvement of the patient's weight and overall feeling of well-being. The next case is a 65-year-old woman who is evaluated for a 6-month history of watery, non-bloody diarrhea. She has a 3 to 20 bowel movements a day. She also has abdominal cramps, bloating, and occasional fecal incontinence, and has lost about 2 kilos. She has been previously healthy. She has not traveled recently. She has not used antibiotics. On physical examination, her temperature is 37, blood pressure is 118/82, pulse of 76, respiratory rate of 14, heart rate is regular, the chest is clear, the abdomen is soft, and has a little bit of distension. Which of the following is the most likely diagnosis? A, Clostridium difficile colitis, B, microscopic colitis, tropical sprue, or ulcerative colitis. What you see in the image here is a normal colonic mucosa on colonoscopy. I just wanted to emphasize that the mucosa is normal. So which of the following is the most likely diagnosis? Clostridium difficile, microscopic colitis is the answer. And the disease is characterized by the presence of abnormalities and inflammation at the level of the mucosa, but it is not apparent endoscopically. It is not tropical sprue, it is not ulcerative colitis. So again, the characteristic of this condition that is important for you to know because it's very prevalent is that it has chronic watery diarrhea, no bleeding, has an unknown cause, colonoscopy is normal, and you need to take several biopsies during colonoscopy to prove the diagnosis. Ulcerative colitis, in contrast from microscopic colitis, is characterized by blood in the stool and significant degree of rectal discomfort. The patient has not taken any antibiotics and does not have other risk factors for Clostridium difficile and has not traveled out of the country and is not at risk for tropical sprue. So remember microscopic colitis. And this is a study that looks at budesonide, which is a medication that we use for microscopic colitis, and you can appreciate if you use budesonide versus placebo, or versus mesalamine, which is another 5-ASA preparation, you can actually treat the disease with much more chances for success and controlling of the diarrhea. The fifth case is a 35-year-old woman who is evaluated for symptomatic ulcerative colitis. So here we know that this person has ulcerative colitis. 1 year ago, she was diagnosed with ulcerative colitis that involved the entire colon and responded very well to initial and maintenance therapy with a medication called balsalazide, which is a 5-ASA preparation. However, 2 months ago, she developed urgent bloody diarrhea several times a day and lower abdominal cramping. Prednisone 40 milligrams a day alleviated the acute symptoms, but unfortunately her symptoms have returned after the prednisone therapy was being tapered. The patient is otherwise healthy and her medications are balsalazide, 750 milligrams 3 times a day, prednisone 15 milligrams a day, and calcium with vitamin D supplementation. On physical examination, her vitals and other findings are normal. Laboratory findings reveal a low hemoglobin of 11, plasma glucose of 140, most likely a reflection of the prednisone use, and stool analysis for Clostridium difficile toxin in A and B are negative. Which of the following is the most appropriate next step in the treatment of this patient? Add oxalazine, add budesonide, add metronidazole, or increase the prednisone dosage to 40 milligrams and add 6-mercaptopurine. So this is a management decision that most likely will require the level of expertise of a gastroenterologist, but I wanted to share this information with you at the primary care level so you know what to expect with these cases. And what you see on the image is a significant involvement of the colon by the process of ulcerative colitis. The answer is to increase the prednisone dosage to 40 milligrams a day and to add 6-mercaptopurine as an additional therapy. Unfortunately, the 5-aminosalicylic acid is not as good for some of these cases of ulcerative colitis. It is used for induction and maintenance and remission of ulcerative colitis, but when it's not effective initially or when the patient develops flare while on 5-ASA, usually we use corticosteroids. And when the corticosteroids are not effective or they have a lot of side effects, at that point we implement treatment with an immunomodulator such as a 6-MP or azathioprine. There wouldn't be any value to using another 5-ASA. Antibiotics would not be particularly helpful here because we're dealing with ulcerative colitis. And budesonide is not an effective agent in steroid-resistant cases. Budesonide is a local corticosteroid that goes to the mucosa mostly. What you see here is some recent work on Budesonide MMX for ulcerative colitis, which allows for more targeted delivery of the corticosteroid in the colon, and you can see that you have some improved performance in ulcerative colitis with this particular molecule. The sixth case is a 25-year-old man who is evaluated for a 6-month history of 8 loose, non-bloody stools per day. He also has abdominal pain and small joint arthritis. The patient has a 5-year history of Crohn's disease, initially treated with corticosteroids, but then maintained an azathioprine therapy. Small bowel radiographic series shows no strictures, but some jejunal-ileitis, which you see on the image, and azathioprine metabolites were therapeutic. Which of the following is the most appropriate additional therapy for this patient? To use 5-ASA, to use an anti-tumor necrosis factor A inhibitor, to use cyclosporin, or to use corticosteroids? Again, maybe a little bit more for the subspecialist, but this is an important issue to know about the use of these agents, the anti-TNF agents, which are important in the management of patients both with Crohn's disease and ulcerative colitis. So this is, in this case, infliximab, which is an anti-tumor necrosis factor inhibitor. The drug is very powerful in bringing the disease into remission while sparing the effects of corticosteroids. Unfortunately, you need to know that there is an increased risk of lymphoma and solid tumors associated with this therapy, and azathioprine dosage should be tapered and eventually discontinued. Corticosteroids should not be used as a maintenance therapy of Crohn's disease because of short and long-term complications, particularly complications metabolic in nature. Cyclosporin is not effective in Crohn's disease, and mesalamine is not effective in people who are immunomodulatory refractory Crohn's disease. And this is the data from a Lancet study that looks at early combined immunosuppression versus conventional management that proves the point that combining with an immunosuppressant and an anti-TNF would actually provide better results. And that ends my presentation on diarrhea. Thank you very much for your attention.
Thank you very much, Professor. It was a very nice presentation with clear-cut messages, take-home messages. Any questions from the audience? I have a question for you, if I may. How often do you use empirical therapy as a first-line approach in chronic diarrhea without special testing, apart from basic blood tests and some stool tests? For instance, according to patient's history, how often do you use antibiotics and probiotics when it smells like functional diarrhea or post-infectious IBS, or in the patients that has a terminal resection, how often do you use empirical cholestyramine?
It's all based on history, depending on how it smells, as you pointed out. I make that decision frequently. I try to avoid overworking up the diarrhea by doing all kinds of studies, including endoscopic examination, if I can avoid it. And we always have what I call the tincture of time. We can start something. As long as we know that we're playing it safe, there's nothing wrong with treating for the presumptive diagnosis for a few days and then reassessing the patient. As long as you have excluded an infection or some kind of a serious process that you may be missing, I think it's very appropriate to do that. And if you suspect that the patient, for example, has bacterial overgrowth syndrome, treating them with a course of rifaximin, for example, or another combination of antibiotics would be particularly useful. And more so in patients with irritable bowel syndrome who have demonstrated this activity over time for years, you can again feel comfortable that this is the same thing again, and you may want to readdress that a bit more carefully this time. So absolutely.